What a rousing call to arms from Mark, and it shows passion, and I'm passionate about prostate cancer. And it's a real pleasure to see some of the people that I've been able to journey with here in the audience today, and it's a real pleasure and an honour also to have the colleagues who I work with. You know, Sue here, we've got some team from Auckland and Counties DHB, and it's a real pleasure to be here today. I like to keep this informal. If you have questions, ask me. This is my proudest moment for the Prostate Cancer Foundation. 3 years ago now, I ran the Auckland Half Marathon, and I had the goal of raising $1,500, and thankfully to my support, I was able to raise over $2,000. I also ran the half marathon in 1 hour 20. It was the first time I'd ever run a half marathon and the last one that I've ever run. So, in my day, as Graham said, I'm a urologist. I work mainly at Auckland Public Hospital, but also in private as well. I've already been to 3 different hospitals this morning to see 3 different patients that I've operated on in the last few days. But something hits me, and it's inequality. I was preparing for this. I was flying down to Wellington this week, and I was sitting on the plane, and as often we do as doctors, we become engrossed in numbers. We become engrossed in research, and I'm preparing my talk, and as we're about getting close to landing, the Māori man beside me just turned to me and he said, "I saw the word prostate on that presentation." He said, "We just buried my uncle 2 days ago who died from prostate cancer." And I said to him, "Oh, how old is your uncle?" He said, 69. I said, "Oh, how long did he have prostate cancer for?" "About a year." He didn't know about prostate cancer treatment. His family had no awareness about what was available to them. He had lived alone, this man, for most of his life and presented with very advanced prostate cancer. He had seizures, he was in palliative care, he was in pain as he died, and it just really struck to me again the inequality that we see in New Zealand for men with prostate cancer. And so that's why I've become involved. I love treating my patients and the journeys, but I see that there is opportunity for us to advance prostate care in New Zealand. And so these are 2 things that I'm involved with. We know the statistics, but it's good to have an update. And these have just been published in the last year, looking specifically at Australia and New Zealand from the Prostate Cancer Report. 1 in 5 men will die of prostate cancer. By the time you're 85, you have a 1 in 7 chance of having developed prostate cancer. It's the 2nd most common cancer in the world. It's an important issue. And the other thing, and I don't personally know Derek Brown or his family, and my condolences to them, he passed away in these last few weeks from prostate cancer. And the thing that often gets me bugged, and I'm sure it does as well, is we get told that prostate cancer is a disease of old men. It is not. Young men are dying from prostate cancer, and we need to raise awareness about that. And so as we've just referred, there are guidelines, and these were brought out, and they're very important guidelines, and when I present to GPs, to different groups, I will always refer to these in terms of what we're trying to do. The problem with guidelines is if you don't actually know if they're in place or not, you can't really tell if you're bringing about improvement in care. And so the government has been working with other cancer groups, and so this was just published this year, the Bowel Cancer Quality Improvement Report. And this was looking at outcomes for bowel cancer patients and reported this. And instantly what it did is create controversy, because once you report something and it's in the news, you got something to hang your hat on. And so this headline came out. And there are issues around actually, is this true or not? But it really highlighted again the difference in access to services for different patients around the country. And people were on the phone to the Ministry of Health, to the surgeons very quickly, and it's already started to raise the awareness for bowel cancer. So we're doing the same thing in prostate cancer. So the first thing that you need to do, though, if you're going to bring about improvement, is you've got to work out, well, what are we actually measuring? And so currently, as said, being part of this working group with the Ministry of Health, we have to come up with the indicators for prostate cancer that are important. And we need to measure those and we need to report those. And if we can do that, we can start to improve care. And by improving care, we will change inequality. And inequality is not just ethnicity, which is extremely important, and we know that the Māori population have a higher rate of death from prostate cancer, but it is also looking at regional variation. You know, I work in Auckland DHB, and I know that I can get a patient an MRI, I can get a patient a transperineal biopsy because they live in the Auckland. They've got that postcode. If they live in a different postcode, maybe in a rural area, they get no access to that. That's not fair. You know, why should it be based on your postcode? We need to have national standards. So this group, and it's important, is made up of a large number of different people. This is not just a group of urologists sitting in a room. This is a group of all different specialties, all different walks, and different aspects. And what are we looking at? So these are some of the areas around the indicators that we are looking at. How long does it take from a man being referred with a PSA to having a biopsy? How long does it take once he makes the decision to have treatment to actually get that treatment? You know, we don't know that at the moment. We know anecdotally that there's a wide variation, but what actually is that timing? And then if we have that, can we actually show that this is an under-resourced area? What's happening after surgery? You know, what are the outcomes for patients from surgery? What is their access to MRI scan, to PSMA PET? You know, who is getting these and who is not? Who's getting radiation access? What are the outcomes from that? One of the things two things I'm really passionate about is multidisciplinary team. You know, I live in Auckland. We have our weekly, both public and now also even a private MDT, where we have at least 20 to 25 different clinicians coming along. You're getting that feedback because you're in the Auckland region. If you're in the rural area, are you even having a medical oncologist even attending that meeting, you know, where you need that access for your care? And also survivorship. You know, it's been highlighted, and I have conversations on a daily basis about the lack of access to incontinence pads, to drugs for sexual function, treatments. You know, where is that happening? And why, if you live in one DHB, do you get 6 pads? And if you live in Auckland DHB, you might get 1 or 2 pads. Where is the fairness in that? And are we reporting this? And the key thing being is that this is about patient experience. This is not about the numbers. Let's base it around what is important for patients. So if you look at the timeline for this, there is a process. Prostate cancer, as we've said, is often near the end of these scales, and so we're still in the indicator coming up with those. We're taking them out to the wider group. We will then need to report, collect the data and then report. So I don't think you'll see a report for at least another 2 years, I would imagine. Why do I do it? As I said, I'm passionate about improving inequality. You know, we need to do that. And that's why another thing that I'm involved with is the Prostate Cancer Outcome Registry. This was funded through Movember, and the goal is that every patient in New Zealand should be able to be included on this database. And the reason why it's so important is stories like this. The whole point of this registry is it is not about surgeon number, it's not about statistics. This is about the outcomes that matter for patients. And so, we know that treatment side effects are often silent, but profoundly can affect a person's life and their partner and families. And therefore, one of the important differences of this registry is not the statistics, it's looking at the outcomes that are important for patients. And this just highlights again around inequality. And so New Zealand, compared to Australia, where Australia has been doing this for a number of years and is getting more mature data, what key thing we can say already is that there is a difference in outcomes between men diagnosed in rural areas and metro areas in Australia. And I would expect that may well be very similar in New Zealand. And also very importantly, showing a 54% difference in 5-year mortality between Māori and non-Māori men in New Zealand. This is from the report that has just been released, looking at the 2016 data. The average age that a man gets diagnosed with prostate cancer is around 65. Again, the average age of PSA is around 7.2, and you can see that here a high percentage of men are diagnosed under the age of 65. This is not a disease of old men. One of the things that I really like about this database is that it has got a lot of what we call qualitative research. That's not numbers, that's real stories. And so, they go around and interview people who have prostate cancer and record that. And so there's some really, really important things. And the comment there on the right, I think, is really important, where they say access to support groups is sometimes variable. And the comment is that for most men who go to a support group, they find it invaluable. And so again, we need to raise awareness of that. It also talks about, how men feel. Often we don't talk about how people feel. We like to just base it on the physical, but there's just so much more to it than that. Touching on the general practitioner, I think the general practitioner, and my wife's a general practitioner, so I can speak on that behalf, it's a difficult situation to be in sometimes. I'm an expert in prostate cancer. My day is prostate cancer. I'll see 12 patients a day. A GP may see one patient a week or every fortnight. And so we need to be equipping them with education about this. And that's why I'm passionate about talking at GP conferences, to try and give simple explanations, because it's hard. They have to deal with a number of different things. We need to bring front and center guidelines to make it easy for them to know what to do. Now, this is interesting data which looks at actual patient-reported outcome measures. So patients who are in the prostate cancer registry, and there may be people in the room who have done that, but this is a questionnaire that gets sent out to them. And I think it's important because it highlights what those outcomes are. It looks at the things that matter: urinary bother, bowel bother, sexual bother. Around 1 in 5 men have a big problem with sexual function after surgery. This is what patients are saying. This is not what data are out there. This is what Australia and New Zealand men are saying. Men on hormone therapy, 1 in 5, big problem. Again, you just told you're taking your Zoladex injection, but there's so much more than that. Urinary function, incontinence, we know it's a problem. We know that sexual function is a problem. We need to have this data so that we can then report it, so we can then aim for change and improve care for our patients. So again, why do I do this? Well, I'm passionate about this. I treat patients with prostate cancer, and I'm passionate that we can improve their care. I don't want to continue to have that conversation. Well, I'm really sorry. Currently at the moment, we don't fund sexual function. You can go to Chemist Warehouse because that's the cheapest, 12 100 milligrams sildenafil for $25. I know that the government doesn't fund it, but hey, we've got to keep on working at it. And for a lot of men, that's all right. They may have that money. But for men who don't, why should they miss out on that opportunity? I'm passionate that we need to bring about change for our patients. I also see it as a real privilege. People often ask me, why are you a urologist? You do rectal examinations and things like that. Surely there was a better specialty that you could have chosen. But I'm ever so grateful for the patients that I deal with. Working with men with prostate cancer, I think, is one of the most rewarding things that you can do, and their families. And I can tell, with partners and family here today. So I see it as a real privilege. I also see it as an opportunity for partnership. I had a patient recently who he'd been in hospital and he'd sat on the ward and he had gone home, and he was obviously a bit of an inventor. And so he came back and he saw me in clinic, and he had this pole that he'd devised, because for catheters, when they got blocked or something, he'd realised that there was a real problem, and he'd gone into his shed and he'd come up with a product. And it was just awesome, because he came and he said, well, who do I need to go to talk to? And I was kind of like, well, I don't know, but let's work on this together. There is partnership when we work together to improve care. And it leads to possibilities. What can happen? As you said, next year, the government year, what can we do to improve care for men with prostate cancer?